Good afternoon. Welcome, everybody, to the third in a four-part webinar series on weight loss and weight management, the current theories and best practices. We want to say a special welcome to the people attending from the Western Region Public Health Training Center and the Southwest Regional Training Center. And then also welcome to fellow HRSA grantees and all other participants. From the U.S., we may even have some people from abroad. So the purpose of this four-part webinar series is to explore and describe the components of a successful weight loss and management program for children and adults in primary care and community practice settings. Here's the learning objectives for this webinar. So you'll be able to identify how pediatric obesity is measured and assessed and describe pediatric obesity treatment options. Just a reminder, in order to receive continuing nursing education units, you have to be logged in no later than 10 minutes after the start of the webinar and must complete the online nursing evaluation form. This webinar series is being brought to you jointly by the Western Region Public Health Training Center and the Southwest Telehealth Resource Center. Before we get started, please mute your phone or computer. Please use the Q&A function of WebEx to ask questions. Questions will be answered at the end of the presentation. I'll be collecting them and try to prioritize those that are questions from multiple individuals. Today's webinar is being recorded, and you will be able to access today's and past webinars on our website. It is now our pleasure to introduce today's speaker, Dr. Wendy Cinta. Dr. Cinta's talk today is titled The Treatment of Pediatric and Adolescent Obesity. A little bit about Wendy. She's a national speaker on childhood obesity, most recently speaking at the American Society of Bariatric Physicians Annual Conference, the Greater Houston AHEC United Against Childhood Obesity Conference, and the World Congress on Childhood Obesity. She is a past member of the White House Task Force on Childhood Obesity, working on initiatives to help empower families by improving readability and content of nutrition labels, school lunches, access to healthy and affordable foods, and increasing physical activity in children. Dr. Cinta has long been recognized as a passionate and energetic teacher. She received her first teaching award in residency from the Society of Teachers of Family Medicine and is a clinical assistant professor of family medicine at SUNY Upstate, where she's conducting research on medically monitored weight loss programs for children. Initial research on her Bounce Childhood Obesity Program will be presented this fall, or was just presented, at the Obesity Society International Conference. She continues to train medical students, physician assistant students, and family medicine residents interested in bariatric medicine, hoping to increase the supply of obesity specialists to meet our increasing national demand. Dr. Cinta is passionate about fighting the obesity epidemic globally and locally and donates additional time to her community to help raise the epidemic. So once again, our pleasure to introduce Dr. Wendy Cinta.
Thank you very much. Thank you. Okay, so let's begin, shall we? These are my disclosures. In case you didn't see it in the last slide, I'm a speaker for ASI, Takeda, and Covidian, and I'm the Chief Medical Officer of 3 Pound Health. So today's agenda, we're going to talk about the stats and general effects of pediatric obesity. We're going to do work on the evaluation of an overweight or obese child. We'll also work on treatment, including what we call our 4-pronged approach, which is dietary considerations, behavioral modification, exercise, and medications. And then we'll do some case studies at the end. Okay, so let's start with stats and facts. So some of this you may already be aware of, but we're in a crisis. There's no question about it. 35% of American children are overweight. 17% are obese. And the latest NHANES data, which was released in February of 2014 in JAMA, showed that there really has been no significant change in obesity prevalence in youth between 2003 and 4 and 2011 and 12. So if you look at the stats, we actually had to create this diagram because for some reason it hasn't been updated recently, but you see we're doing a good job on the younger children, 2 to 5 year olds. We have that sort of sawtooth pattern, so we seem to be trending downward, or at least staying the same. With the 6 to 11 year olds, that's a green line. It was pretty consistent through the last couple years, and the 2 points, and we'll look at the exact numbers in a second. 12 to 19-year-olds, unfortunately, we're really struggling with, and they keep heading upwards. And we'll discuss that a little bit more in the upcoming graph as to why that is. So there's the real numbers there. So green means it's gotten better, and red means it's gotten worse, and blue is staying the same. So if you compare the data from 63 to 70 to 2011, 2012. So just so you know about NHANES, it's data taken mostly by phone calls and, different type of measurement techniques. It's done every 2 years. And what they do is they try to compare, data in children via families most of the time, sometimes through doctors' offices. But at any rate, 2 to 5 year olds were at 8.4%. 6 to 11-year-olds, 17.7%, right around that 18% we were before. The 12 to 19-year-olds are 20%, and overall we're still, unfortunately, at that 17% for all children, which is really too high. And this is obesity. This isn't overweight. This is strictly obesity, 33% if you include overweight. So this is a problem right here. This is very well represented in this graph here for JAMA in 2014, JAMA Pediatrics. And something that I think is so important to understand when you're looking at any type of obesity is the fat cell runs the show after a while. And what ends up happening is over a period of time, we are actually, we become resistant to our own ability to control appetite. So if you look at the graph here, you see the all obesity is the yellow, the class 2 obesity. Now, these terms, it's interesting they use this for this diagram because these are adult terms, but you kind of get a sense. They get bigger as with the different classes. But at any rate, as the child gets bigger into the class 3 category, you see that it keeps getting worse and the numbers are increasing, okay? And part of that is because as you keep gaining weight, it becomes much harder to control your own appetite. Our body's innate ability to control appetite through resistant enzymes that come from the fat cells no longer work appropriately. And so you end up getting what's really considered a resistance to being able to maintain your own satiety. So, and that happens through chemicals like you've probably heard of leptin and ghrelin and, just a complete utter imbalance of those. You get what's called a leptin resistance. Leptin is something that actually controls hunger, and your body becomes resistant to it over time with an unhealthy fat cell. Okay, so I don't want to belabor the whole cost of childhood obesity, but for those of you that are in the public health world, we are in a crisis. With adults, it's expected by 2030 to affect 25% of our healthcare budget because of all the comorbidities with obesity in general. They did a really neat study in Pediatrics in 2014 that looked at the cost of a single child, and what they found was incremental direct medical costs are $19,000 per obese child when compared to a normal weight child who remains normal for the rest of his or her life. So you can see here, this problem isn't going away, and it's going to bankrupt us even more so than it already has. Okay, so those are the basics. Let's talk about evaluation of an obese child now, obese or overweight. So many of you are familiar with these charts. These are percent BMI charts that are used to calculate what is termed percent BMI for children. Now, in adults, we have body mass index, but that's because our growth has been completed. With children, we have this growth potential, so we have to do it based on their age. There's a separate chart for boys and a separate chart for girls. So the terminology, overweight and obese, if it's less than 5% on the percent BMI chart, it's considered underweight. 5 to less than 85% is a healthy weight. That's what you want to aim for. 85 to less than 95 is overweight. 95 to less than 99 is obese. And then greater than or equal to 99% is severely obese. So this is kind of a neat chart that's also on the CDC website, and it just sort of shows you how to take a child with a specific BMI and how to graph them. So for this particular 10-year-old boy, if you look at the x-axis there, if he's 10 years old and his BMI is 13 on the y-axis, then you see that he actually falls into the underweight category. If his BMI is 18, he falls into the green area there, which is healthy. If his BMI is 21, then he's considered overweight. And if his BMI is 23, he is considered obese. So you see that is the representation of how you would graph it with the percent BMI. Okay, so once we calculate based on percent BMI, and just to show you, most of the patients that I see are way up here. It's very rare once they get to my office that they're in the lower range there. But once we calculate percent BMI, we then want to focus on, their family history, especially as it relates to obesity. So the questions we need to ask are, is there obesity in the family? Is there diabetes type 2, cardiovascular disease, including cardiac events, hypertension, dyslipidemia, hypothyroidism? Those are the things you want to ask for specifically. You really want to get a sense of what's going on socially with these families. So much of how we eat has to do with the environment we're in, both at home and away from home. So the number one thing you want to do is get a sense of the family dynamic. So is dad off doing his own thing and the rest of the family's trying to be good? Is there a skinny brother that is perhaps not, overeating, and they're letting that child overeat because they're trying to put some weight on, but then they're restricting the child that you're seeing? How is that child doing in school? What's the feedback from teachers? Is the child getting picked on? That kind of thing plays a huge role in eating habits. Who else feeds the child besides parents in school? I think if there's one thing that sometimes gets forgotten, it's that you have to look at that child's entire day and see who can affect the eating patterns of that child as the day goes on. And that can be sometimes a daycare provider or a grandparent or somebody else that takes the child, especially if the parents are split. There can be completely different eating patterns when the child's at one parent's house versus the others. And then things like a divorce or a death or a move or a school change or other life-changing events, all of those things can play a role into why we eat the way we do. So once you get into the social history, then you want to look at the birth history and the past medical history. Some things that are very important from a birth history is the weight of the mother and father weight of the mother and the father of the baby at the point of conception. That's what predetermines the genetics at the point of conception for mom and dad. Were there any pregnancy complications such as gestational diabetes? What was mom's weight gain, especially in the third trimester? That can have a huge effect on what that child's weight ends up being later on in life. Is the child small for gestational age when he or she was born or large for gestational age? Both are risk factors for obesity. And then is the child breast or formula fed? So this is kind of interesting, and if you've been following this, a little bit controversial. And part of that is because we thought that breastfeeding was protective, and recently it looks like perhaps it's not in terms of obesity. However, I will tell you that, we all know that breastfeeding is good for so many other reasons. And something that is apparent in the data is that there is a learned behavior about what that child sees as normal. So, for example, if mom's feeding the child, is breastfeeding, and she's eating a lot of healthy fruits and vegetables, it's believed that there's a memory that is passed in the breast milk to the child, so that the child will then have an interest in those foods and recognize them as something that he or she has seen before, versus if the parent is eating unhealthy. So that's something to sort of keep in mind that I think is interesting in the data. As far as the past medical history of the child, was there a rapid rise in weight? Often we see this in the pre-toddler stages, or we'll see it in the prepubescent stages. Was there an absence of rebound adiposity in toddlers? So when they start running around, did the weight not go down as it would normally be predicted to do? Was that child ever on steroids or weight-gaining meds? And are there any other previously diagnosed comorbidities? When we're dealing with children now, you really have to think about some adult diseases like hypertension, high cholesterol, elevated liver tests, sleep apnea. Those are things that perhaps 20 years ago weren't even on our radar, and now they're unfortunately quite common. And then also genetic disorders, Prader-Willi, congenital hypothyroidism, and then some really unusual ones like Bardet-Biedl, Cohen, and Elstrom's are things that can affect the child's weight. This is extremely important. Weight-gaining medications, and the thing that I want you to really pay attention to is the medications we use for depression, anxiety, and the antipsychotics and mood stabilizers, because this is a huge problem. If you look, if you study this a bit, you can find that there is a lot of information on the web from children who take these meds, and they blog about it, and they really do feel that they have to make a decision between being heavy or being stable mentally. So there's some great research on this as far as things you can combine these meds with, to help with weight loss, which are outside the scope of this talk, but it's something to keep your mind on. But anyhow, antidepressants, the SSRIs, of course, Paxil is black label for children, but it's something that you need, black box, something you need to think about if they're older. Sertraline, citalopram, and escitalopram, those are weight gainers. Antipsychotics, especially the second generation, and mood stabilizers, the ones listed here. Risperidone is a big one. Divalproex sodium, olanzapine, big weight gainers. Hormones and steroids like oral contraceptives, any form of progesterone, and prednisone, particularly for the asthmatic children that have been on and off them. And then other medications such as insulin, gabapentin, and beta blockers. Okay, so important. So we did their history, social, physical. The other thing now that we need to do is look at their dietary history. And this is the what, where, when, and with whom. And these are, the more you read about what our children are eating, the more amazed, even now that I've been doing it for 10 years, I am. And I'll show you some interesting things coming up about what our kids are eating. But we do know in general, too much sugar, too much fat, not enough whole grains, not enough fruits and vegetables. Many of our children skip breakfast. That is a huge problem. Too much fast food, drinking the wrong fluids like sugar-sweetened beverages, and certainly not enough protein. So in addition to the nutrition history, you have to also think about the exercise history. Is that child exercising at all? Does a child have physical education in his or her school? What does she enjoy doing? How often is he or she gaming or watching TV? So this is critical. There's a significant association between high screen time and the prevalence of childhood obesity, and the response in all age groups seems to be dose dependent. So as I tell you this, I will also tell you that the issue is not in general exercise. The issue in general is food. Most of the kids that I see at my practice, even my really big kids, do move some. And it's really what they're eating and when they're eating it that is making the big difference, and how much of it they're eating that is making the big difference in their weight. And I'm certainly not trying to discount the exercise component of it. It's very important for so many reasons, but it's not the biggest player in this epidemic. Okay, and then finally, a focus review of systems. And what you really want to do is just kind of ask these questions and then pay attention to the answers. Some of this might seem very, very obvious. So, for example, nervousness, school avoidance, social inhibitions. Always think about depression, anxiety, and bullying. Bullying is huge. Bullying is still a big problem. We go through it in my children's schools still, regardless of the fact that we've tried to put pressure on the administration for it. So it's something that you should consider happening rather than not happening. Now, bullying oftentimes can come from their siblings as well, and sometimes the siblings can be so much worse than even their schoolmates, but it can happen, and it happens all too frequently. Fatigue and muscle aches, you want to think of vitamin D deficiency, extraordinarily common in these children. You should check vitamin D in all of them and treat it. Polyuria, polydipsia, fatigue, think of type 2 diabetes. Headaches, facial numbness, think of pseudotumor cerebri. Skin pigmentation, skin tags, increased hunger, you want to think about insulin resistance. Daytime somnolence, loud snoring, witness apnea, sleep apnea, so common in these children. Abdominal pain, indigestion, you want to think of GERD, gallbladder disease, and constipation. Hip or knee pain, think of slip capital femoral epiphysis or early arthritis. We're seeing arthritis in these kids already. It's unbelievable. I fear for the future of joint replacement surgery, because if we're seeing it, I'm seeing it in some of my 14, 15-year-olds. I can't even imagine when they're going to be getting replacements. In towing, leg bowing, mild knee pain, Blount's disease. Okay, and so now on to the physical exam. I think one of the most revealing things in the physical exam is the skin itself. So some of the things we want to look at are acanthosis nigricans. And so this is a hyperpigmentation of the skin related to insulin spilling into the melanocytes. You'll normally see it across the neck or under the arms or, under the breast or sometimes in the abdominal folds. And the degree of insulin resistance is directly related to the level of insulin we have found. And what we've also found is as the child loses weight and then the insulin resistance resolves, in other words, as their insulin in a non-growth state returns to normal, the acanthosis actually goes away. So keep a good eye out for that. If you see something like that picture right there, I am certain that they're insulin resistant. Hirsutism, especially in the PCOS girls, look for that. Stria, so when I was younger, or not younger, I was younger, but when I was in medical school, they taught us about stria being related to things like steroids. Well, I think much more commonly now we're seeing stria related to rapid weight gain. And so what you really see here is gives you a little bit of an idea of how fast the weight came on with this when you see it on their arms and legs and belly. And then intertrigo, look for this. You really have to lift up the skin, especially where it folds, and take a good look for this rash. It's extraordinarily common in these children. Okay, great. Okay, so we talked about skin. Next, we were going to talk about the mouth and neck. So sorry about that, everybody. 30% of obese children have sleep apnea, so sleep studies may be needed. So something you want to look at is a couple of things. Number one, you want to look at the size of the tonsils. Oftentimes, one of the treatments for sleep apnea is just taking like a TNA as part of the treatment plan. Also, look at the weight around the face, look at the weight around the neck, look at the size of the tongue. Those can also give you signs of whether or not that child has sleep apnea. Then we want to look at the neck. So as far as the neck goes, super important to think about the thyroid. Now, thyroid in children, at least lab values, can be misleading in some cases. So 10 to 23% of all obese children can have elevated TSH levels, but they would have normal T3 and normal to slightly elevated free T3 and free T4. So what they believe this is due to is low-grade inflammation of the thyroid tissue and leptin-mediated production of pro-TRH. So the point is sometimes you can have an elevated TSH. It does not mean you should jump on treating that person for hypothyroidism if it's a child. What you want to do is check the antibody levels, follow it. As the child loses weight, oftentimes the TSH will return to normal. Okay, abdominal exam. So 1 in 3 obese children have fatty liver disease. Severely obese children also can have 40% higher risk of reflux than normal weight peers, especially if they carry their weight in their abdominal area. And shockingly, so for adults, it's 5 times more common to have gallstones with weight, but with children, it's 8 times more common. So please pay attention to abdominal pains, and don't be. I think sometimes we're a little bit slow to order blood work, and part of it is because the screaming child in your face with 4 people holding him or her down isn't always a pleasant thing to deal with in the middle of a very busy day, but certainly when you're working on abdominal pain in these obese children, you really have to work them up for things like acute gallbladder disease. Okay, orthopedic exam, you want to look for Blount's disease, which is external tibial bowing. You want to look for slip capital femoral epiphysis, which is pain along with a limp related to disruption in the growth plate of the femur. All right, and now we're moving on to lab values. So if we're going to look at the expert panel recommendations from 2007, as far as lab work goes, they're actually very minimal. 85 to 94% BMI without risk factors. They recommend fasting lipid profile. 85 to 94th, ages 10 and with risk factors. They represent fasting lipids and glucose, and then ALT and AST. And then for BMI greater than 95th percentile, fasting lipid profile and glucose, ALT, AST, and other tests as shown or indicated by health risk such as thyroid function tests. So I would urge you to consider things like fasting insulin. As I mentioned, it can really tell you a lot about the child's hunger. So the higher the insulin, the greater the leptin resistance. The greater the leptin resistance, the less likely that child is getting full after eating. So the more likely they have issues with satiety. So I check fasting insulin, but you got to also remember that the insulin can change with growth. So, you have to factor that into the equation, where the child is in the growth cycle. I always check a lipid profile. I find more often than not that that they do have low HDL, high LDL, high triglycerides. I would want to know that because sometimes it gives you a little more information to show the parents. When you start to show some obesity-related diseases, certainly it gives them a little more impetus to do something about it. I check a blood count. I check a metabolic profile, CPK, only because I want to just make sure that these children are not losing muscle as they work on their weight loss, and the CPK can sometimes reveal that. And also, if you do need to put a child on medication for cholesterol, I have never done it. I usually work on the diet, but if you do, you want to follow that. Hemoglobin A1C, I check vitamin D, uric acid almost always, or very often, I shouldn't say almost always, very often elevated in these children, thyroid functions, and then I check urine as well. Okay. All right, on to treatment. Okay, so if we're looking at the elements of a childhood obesity program from obesity medicine specialists, they really are, there's 5 pieces of the pie you can consider it. So number 1 is nutrition, and then we've got exercise, we've got the medical monitoring piece, and then behavior is sort of split into the behavior of the family and then the behavior of the child. So let's start out with nutrition. I know we have a lot of nutritionists on this call today. So I was amazed when I dug this graphic up about what are the top 25 sources of calories among American children. Number 1 is grain-based desserts such as cookies, cakes, and donuts. So that is the number 1 source of calories in our kids, and we wonder why we're in trouble. Number 2 is pizza, and number 3 is soda, energy, and sport drinks. And then if you look down the list, you see a lot of carbs. You don't see much in terms of protein, and the only vegetables that are up there are French fries. So it is obviously what they're putting into their mouth more than anything. So if you look at the data on nutrition for children, there's a lot of different ways we can approach this, and what I want to do is just kind of show you what's been studied, and then I'll tell you what I do in general. So for one of the things that have been studied is low-carb plans, and the rationale for low-carb plans is to reduce carbohydrate intake significantly. If you reduce carbohydrate intake significantly, you can get the child into a state of ketosis, which can cause a decrease in appetite and subsequent decreased caloric intake. So the trials vary in terms of carb restriction, fat composition, calorie restriction, age of patients, duration of intervention, post-treatment follow-up, and comparison groups. And if you look at the data you see, and some of them are listed there below, all studies include interdisciplinary team, including an RD who assessed adherence to the diet. Compared to baseline, all studies reported a significant improvement in weight status at the completion of the intervention. So as you can see, we have a long way to go with carbs. That's, what most of our children are eating most of the time. So any kind of decrease in carbs and increase in protein is going to most likely help with weight loss. And the data does show that. Now, as far as my references go, some of them, if there's just a few, are going to be on the slide. And then I believe you're going to be getting something later that has the rest, or it may be at the end of the presentation. But there are some slides that have so many we couldn't put them on. Okay, reduced glycemic load. So this is something like, the South Beach diet, if you've heard of that. The rationale is high glycemic index foods are associated with an increase in blood sugar followed by an insulin response, leading to a rapid decrease in blood sugar and then increased hunger, leading to increased caloric intake. And oftentimes when your sugar drops, you don't go for a piece of chicken, you go for something like a sugar or a carb to bring it back up. So as far as this diet goes, there's been 4 trials, and they vary in design, age of patient, duration of intervention, size of the group, etc. But all of them included an RD, and compared to baseline, they all showed a significant improvement in weight status at the completion of the intervention. 2 of the studies had post-treatment follow-up reported that there was improvement in weight status, and these improvements were maintained. So I think the take-home message from both of these studies is anything you can do to reduce, especially the starchy carbohydrates and sugar, are going to be very helpful from a weight loss perspective for children. There's also something that's been around since the 70s called the stoplight diet, and you may be familiar with this. The rationale is it's a less restrictive approach, and it increases the emphasis on eating healthy foods like fruits and veggies, low-fat dairy, decreased intake of high-energy dense foods. So remember, though, the stoplight diet came around in the low-fat days, it's a little bit different approach that we take now in the low-carb days. But at any rate, green was low-cal, high nutrients, and you can eat those often. Yellow is moderate cal, mostly grains, eat in moderation. So that's, again, one of those things that we want to kind of step a little bit more away from now. And then red, high-calorie, low nutrient, and you want to eat sparingly, and those are like the high-sugar foods. So there have been some trials on this. 2 randomized clinical trials vary on size, intervention, duration of intervention, and follow-up, and the ages of the children were 8 to 12. Compared to baseline, all studies reported a significant improvement in weight status, which was sustained long-term. So what's kind of neat about the stoplight diet is it really does speak in the child's language, and it really is more of sort of an elimination type approach. So, and it teaches them healthy eating, and that's what I like about it. What's not so great about it is it's kind of outdated with the low-fat teachings of the past. Okay, so now we look at VLCDs, or very low-calorie diets, and the studies on that in children. So these are diets that are less than or equal to 1,000 kilocalories per day. A protein-sparing modified fast is one of them, which is 600 to 800 kilocalories. That's high in lean protein and low in carbohydrate. And then there's also a hypocaloric balanced diet that's a little bit higher in calories. Both interventions have been studied and used as part of a comprehensive weight loss treatment, a weight management program to induce rapid weight loss, 10 to 20 weeks, followed by nutritionally balanced diets of about 1,000 to 2,000 kilocalories per day. And these actually had some very nice results. So the clinical outcomes showed significant weight loss short-term, 6 to 12 months. They didn't examine the long-term effects. There was some concern about growth velocity for stature, but the findings were very inconsistent, and studies since this time have not shown that to be a problem. So, but still, we're dealing with children, and we want to be careful. So the recommendation is short-term use of these diets, 10 to 12 weeks by many weight loss experts. I like the particularly protein-sparing, or not the hypocaloric balanced diets for my very big kids, because you can get a lot of weight off very quickly, and the data does back you up. But you really have to see these kids weekly because you can get electrolyte abnormalities, etc. Okay, let's keep going here. And then meal replacements. So meal replacements, the rationale is high-protein shakes and bars can produce satiety, cause stimuli narrowing, so the brain just sees the same thing coming in, is much less interested in food in general. And then it also, you can get a greatly reduced calorie intake due to the decreased personal decision-making. So there's consistent evidence about meal replacements with adults, and they're very effective in a safe strategy to produce significant sustainable weight loss. I use them a lot in my adult patients. The one RCT of meal replacements in children did show that the meal replacements significantly increased weight loss during the first 4 months, but they didn't facilitate the maintenance of the lost weight at month 12. So I think the take-home message is great for short-term weight loss, but you also have to follow it up with something that's going to introduce the food back in and then help stabilize the weight long-term. Okay, in the interest of time, I'm going to skip this slide because we had that little break there. Okay, so finally, we have my favorite, which is an elimination diet. So what I like about elimination diets is you get a sense of what's going on in that family, what that child is eating, and then you slowly and covertly remove the bad stuff and replace it with the good stuff. So I have a program that's called Bounce. I think we talked a little bit about it in the introduction. And basically, I have a 5-step approach to my elimination diet. And each step is performed for a couple of weeks until the family has comfortably incorporated the change. So the very first thing we do is step 1, we eliminate the sugar-sweetened beverages and switch to water and low-fat milk only. Okay, so a child needs to really just drink water and 1 to 2 glasses of low-fat milk a day during the growing years. The higher fat before they're 2 years old, but even those recommendations after 1 have changed to lower fat after 1 in an obese child. Then the second week, we replace high-fat junk food with healthy alternatives, and then there is an increase in protein that occurs. So what I do is pull out the carbs, put in more protein. We add fruits and vegetables. And then step 4 is substituting in healthier carbohydrates. So, complex carbohydrates, whole grains, that type of thing. I love ancient grains like quinoa. I think those are great. They really keep the child full. You can even get, if the child is hooked on pasta, you can do things like protein pastas that are available out there. But basically, you want to keep the child full on less calories. And the last step of this is minimizing saturated fat and completely eliminating trans fat to the degree that you can. Okay, now on to behavioral modification. And here it is so important to work on the behaviors of the family. So just so you know what kind of things we're dealing with here, 41% of U.S. adults reported eating away from home foods at least weekly, and 25% to 30% and 30%, 25% of children, 30%. 25% of adults, 30% of children reported eating fast food at least daily. Frequent consumption of fast foods, as you probably know, is associated with poorer diet quality and risk for obesity in both children and adults. So I tell people right away, cut your eating out, especially your fast foods, to no more than once a week. If you tell them they can't do it completely, you get some balking. But if you can at least cut it down to once a week. And also there's some better alternatives to to some of the fast food restaurants. There's some that are healthier, like Subway and, things like that. So there's ways you can do it without completely making it a bad experience. I'm big on this, cooking together and eating together. And it is so important for so many reasons to do this. It gives your children appreciation for the food that they're putting in their mouth. It also helps from a social standpoint. So the benefits of sharing 3 or more family meal times per week include a reduction in the odds for overweight by 10%, eating unhealthy foods by 20%, disordered eating 35%, and an increase for the odds of eating healthy foods by 24%. Now, I didn't even mention the benefits socially in terms of substance abuse for these children, drug, alcohol, all made better if you sit down and eat together. You get a better sense of what's going on with the family. Something I do in the children I take care of is I tell them no electronics with food. That means mom and dad too, TV off, hand the cell phones in a basket, sit down and talk to each other. No outside stimulation. All you need is each other. Okay, and then, behavioral modification is really, really critical. And they've studied this, is it better to look at the parents? Is it better to work on teaching the children? Is it better to do them together? Really what they found is, first of all, if you deliver a family-based therapy between 6 and 12 years of age, it can last into adulthood. So something you do with the family to help modify the family's eating habits, purchasing habits, etc., can help that child into adulthood. So it is worthwhile for sure. Some of the research from the past by Dr. Epstein, listed here at the bottom of the slide, showed that actually research with just the parents, so this particular study had child and parents, child alone, and then just sort of a non-specific group. But when they studied just the parents, there was even a better weight loss that was maintained. So what I do is I actually have my kids doing something with exercise while the parents are in a meeting to talk about behavior as part of my group that I have with my Bounce program. Speaking of exercise, they have studied exercise in children. And what they found is depending on the degree of obesity, the recommendations for exercise have been about 1 hour of physical activity per day for less than 12 years old. So yes, so important to get them moving. Some of the electronic apps help. There's one called Moves that is free on iPhones and things like that. You know that we have Fitbits and all sorts of gadgets that you can use. Even a simple $5 pedometer can help, but anything you can do to get the kids moving. It's hard to talk about exercise without talking about play. Children don't play anymore. It is so important to get them out there playing because it helps with socialization as well. And hopefully we can see a resurgence in this. People are certainly onto this whole concept now. Walking is always a good idea, even for the bigger kids. If the kid's just too big to even walk, putting them in a pool. We actually have some physical therapy places that have treadmills in the pool that children can use. And being buoyant, it helps, and they can still get the advantage to their muscles, and it feels good. But bike riding, hiking, obstacle courses, dancing, playing as a family, all of those things are helpful from an exercise standpoint. For the older kids, it's the same kind of idea, but you can actually do some weight training for these children. Wii Fit, some of the Xbox Connect, some of those things can also be helpful as well. Okay, now let's talk about medications. We'll just do a little time check here. We don't have much because of the whole screw up. I apologize. Okay, so the ideal medication for children, of course, is one that is safe, effective, daily dose, does not affect growth or development. So the only one that has been studied by the FDA is Orlistat. This is a drug that inhibits gastrointestinal lipases, reducing approximately 30% of ingested dietary fat. Orlistat was 120 milligrams TID. It has been approved by the FDA. It was approved in 2003. It is actually appropriate for 12 to 16-year-olds. It's over-the-counter as Ally. And they did a very large trial with a lot of kids, but the dropout rate was very high there. You can see 35% due to side effects. So I never touch this drug. Off-label use. So this is sort of where we're at. So if I can give you a couple of pearls, there's two that I think are really crucial for weight loss success in a child. Number one is you have to have an engaged family that is willing to make the changes in all the family members. And number two is you have to be able to get control of that child's appetite, or it's like banging your head against the wall. So so you have to, unfortunately, and until we have some data, think about off-label use. So off-label is a drug that's prescribed for periods of time that is not FDA approved for that particular application. So off-label drug use has been studied. In March in 2009, there was a study in American Pediatrics that showed 62% of outpatient visits resulted in off-label prescription use. According to the FDA, if a physician uses a product off-label, he or she is responsible to be well informed about that product, blah, blah, blah. So you have to really make sure that you read about it and the side effects of it. And then you want to be able to make sure that the family understands this is an off-label use of this product, but my experience has been this. And I actually have them sign a waiver just so that it shows that I did explain that to them. But I will tell you it has helped. It does help my practice. I'll talk about a couple that I use. I am a big believer that metformin is a very helpful drug for children that are 10 years or older. And if you don't know, it's a biguanide that inhibits intestinal glucose absorption, and it reduces hepatic glucose production, and it increases insulin sensitivity. And when your insulin sensitivity increases, your appetite goes down. There's been more than 20 studies on metformin now, and it shows that it improves body composition, fasting insulin, body mass index, cardiovascular control, and fatty liver disease in obese children and adults. Start at 500 milligrams twice a day, titrate up to 1,000 twice a day. There is extend-release form dosing. It's better tolerated, and aim for 2 grams a day. Topiramate can be very helpful for those children that are big bingers in particular. So it's a GABAergic anticonvulsant used for seizure disorders in children over 2. It's been used in children with epilepsy and migraines. And even in those children, they weren't working on weight loss, but that was a 1 to 2 kilogram decrease in body weight versus placebo. It has been studied in the antipsychotic weight gain, and so has metformin, by the way. So if you have children that are on antidepressants or antipsychotics, there's been some nice data showing that both of these drugs help prevent that weight gain that can be associated with that. And it's been effective in adults with binge eating disorder. If I do put a child on it, it's usually an older child, and it's 25 to 50 milligrams at night. You have to be so careful because it can be teratogenic. There's a 1% increase, 0.1% increase in the cleft lip and palate. If the child is sexually active, they have to use some form of birth control. Phentermine. This is an oldie but goodie. Been around since the early 60s. And they actually did study it in children back then when they did wild and crazy things like that. And what they found is it had excellent weight loss, 5.2 kilograms in 3 months, better than anything that we have out there now. And it has had a very good side effect profile. It's approved for adults, and it's therefore anything that's approved for adults is assumed to be safe for children 16 years or older. We now have long-term data on phentermine for adults. And when you're thinking of the sympathetic load for phentermine, it is very similar to those drugs used for ADD. But again, because it's off-label, you really have to be careful to make sure you explain this to everybody. Diethylpropane is a shorter-acting version of phentermine. And then what I have done is pulled it all together in my program called Bounce. And so just to, if there's something that you can do that can help, I wrote the book not to, if you've ever written a book, you don't make money on the book, but you hope that you disseminate really good information to people so that they can answer questions or ask appropriate questions. So the whole idea was to help parents and families make some of these changes at home. The acronym stands for Behavior, Optimizing Metabolism. My children eat 3 meals and 2 snacks a day. United as a family, everybody makes the changes. Try to write down your food so you know what you're eating. Count your steps by using a pedometer, and then I work on the elimination diet that I told you before. So I am thinking it's 2:55. Maybe what we should do is go on to questions at this point. What do you think, Myra?
We just have a couple of questions. Maybe the case study might be a little more helpful, and people can email them in, the questions, and
okay.
Maybe
Should we do that?
Responses. I think that might be a little bit more helpful.
Okay, let's do that then. And again, I'm so sorry.
Oh, yeah.
To be in this predicament. Okay, so Aiden, an 8-year-old child. 4 feet 2 inches tall. He weighs 88 pounds. His BMI is 24.7. So, what do we do? What do we focus on? What should our initial treatment be? And what would our next steps be? So I think the very first thing we have to do is plot him on the graph. And as you see here, Aiden is in the greater than 95th percentile. So he, because of that, he's considered obese, and I believe he falls into severely obese if you look at the tables that show that. So what I would do with Aiden is I would worry about comorbidities in these children. I would check the blood work, such as the hemoglobin A1C, a comprehensive metabolic panel, thyroid functions, fasting insulin level, vitamin D, and anything else that would make me suspicious. And for Aiden, what I would probably do is, how old is he? He's 8 years old. I think depending on his weight, I would consider starting him on, well, the first thing I do with these children is, before any medications, you try to maximize protein and see if you can get them full this way. So I've had many Aidens walk through my door. The biggest problem was, in many cases, their quantity of food that they're eating. And so what I would do is I would start them on an elimination diet, and I'd try to maximize protein and see if we can't get him fuller on the protein first because he is young. If it turns out that even by, bumping up protein, giving him protein in breakfast, lunch, and dinner, we're still not able to fill him up, then I would consider adding metformin in a low dose to this child because sometimes that can make all the difference. And even, for younger kids, even 500 milligrams twice a day or 1,000 a day can make all the difference in the world. And it makes it much easier for them to stick to the diet. And then I would do the elimination diet. I would focus on putting him on a higher protein, so maybe some eggs for breakfast and a nice healthy lunch with minimizing the bread, put some fruit on the side, and if they're doing any kind of chips, I would make them baked, and then I'd eliminate them out entirely and maybe switch over to something else like kale chips, which are delicious and healthy, and then a very healthy dinner. And there's a lot of less than 100-calorie desserts you can find in the frozen area if he feels like he needs to have something sweet at nighttime, maybe the frozen yogurt bars and things like that they have, or even just yogurt with fruit. So that's what I would do, and I'd see Aiden every 2 weeks, and I talk very, very in great detail with the family about their eating habits. If Aiden is that big at 8, there may be, another parent that's struggling as well. So certainly I get them into behavioral groups and focus on their eating behaviors as a family. Diamond is a 12-year-old. She's 5'1". She's 130 pounds. She's just overweight. Her blood pressure is 106/70. If we plot her out, we see that she falls in that overweight area, 93%. And in someone like Diamond, you have to be careful because I think too often we say they'll grow into it. But truly, in someone who's in the overweight category, definitely you want to work on eating habits and behaviors, but you don't have to get quite as aggressive. If we can just get her eating healthier, cutting back on the carbs makes all the difference in the world, increasing her fruits and vegetables, increasing nutrition overall, and just following her hunger. Sometimes just a matter of changing breakfast or eating breakfast can make all the difference in the world. She may do fine just growing and maybe losing 5 to 10 pounds is all she'd need to get her on track with some growth. So I think it would be a little bit less aggressive. But again, you can still use an elimination diet in a child like her. Okay, so here's my last slide. So in summary, it's hard to summarize this because there's so many pieces at play, but I would say the childhood obesity epidemic, it is a very serious threat to the long-term health of our children, certainly the fiscal health of our country. Something we really didn't talk about is how do we really get this to stick? And I think we really have to focus on getting families to understand it. And I do a lot of talks at churches. So everything that we need, we already have on this earth. And what we've done is we've sort of messed it up and turned it into this, kind of pseudo food products that we make shelf ready. And if you start to stick to the things that come from the ground and the things that you can, healthy lean meats and things like that, or even vegetable-based proteins, you will do just fine. So we have to decrease the demand for these things. I don't think we're going to be able to ward off the food industry. They are too strong and powerful, but we can at least decrease the demand for the things that are so bad for our children and are really hurting all of us. Medications can be necessary to help control appetite. It's so important. It's important to have a multidisciplinary approach. Behavioral modification is the key to maintenance, and it has to be the key to changing in the family. Again, you got to have the child's appetite controlled, and you've got to have a family that's willing to make the changes as a group. And then finally, the successful reversal of childhood obesity has to involve a wide array of public and private partnerships to work together in concert. In the book, I actually have an example of where that was done very well, which was in Naperville. And they did some really, really cool things there that had the private and public sector working together to help improve the health of the community with a great BMI drop in the children affected. So grassroots efforts are included, and we can all play a role by using our talents within our own communities. And that's it. Oh, those are my kids that I've taken care of. Probably the biggest losses are on the top there. All of those kids on the top have lost over 100 pounds. And some of my younger kids are on the bottom. And most of these you'll see here are just one single school year. So once you get control of that appetite, it makes all the difference in the world. All right. And that's my daughter on the right is Marilyn Monroe and her friend. Thank you. And sorry again about the technical difficulties.
Oh, not a problem, Wendy. Chris and I are collecting up the questions that we'll send to you. And just to kind of wrap up the webinar, because I know people need to get off, our next webinar is Tuesday, January 12th, and I'll actually be presenting the adult bariatric case study. And please come to our website if you want to register for that. As always, we value your opinions, and please take a few minutes and complete the online survey. And just one last reminder, in order to earn your CE credits, nursing credits, you need to fill out the evaluation form. So thank you once again, Wendy, for a very interesting talk. And I'm hoping as part of the response to the questions, you might offer some resources around non-competitive sport type programs that our listeners could access or learn about, and other grassroots and things that they can get involved with or promote as far as increasing reimbursement and funding for exercise and diet programs, both from government as well as private payers.
We'd be happy to. Thank you.
Thank you very much, and appreciate it. Thanks, everyone, and thanks for signing in. Thank you.
Thank you.